ask questions and state your opinions. But we are going to start off with the panel. So the first one is, what does weight tell us about health? And I want to, without putting anybody on the spot, I do want to start with Corinne herself, because she's told us that she's lived most of her life as a fat person. But apparently, despite experiencing all of the bias and stigma and discrimination and the problems, physical problems that she's talked about, it wasn't until she was 40 and she apparently had this conversation with the doctor that she just told us about that she decided, well, something needs to happen. So I want to talk to you about the time before that. When did sort of your health come up as a reason, or was that ever anything that you were concerned about, or were you far more concerned about your looks, or were you not concerned about your weight at all?
I actually think that, growing up and in my 20s and 30s, that, yeah, I was fat, but, I was a healthy fat. I thought I felt pretty good. It wasn't until I started to get a little bit older and realized that I wasn't as healthy as I thought I was. I was, lying to myself, which I think, as a morbidly obese person, we do an awful lot of, right? Oh, it's not that bad. Yeah, so what? I'm in a size 24, right? I mean, things could be worse. And it is. It's a lot of that lying to yourself. And so I don't think I really allowed myself the opportunity to let that reality sink in, because I think it was too painful to admit to myself the truth.
Okay. All right. So what I'm hearing is that you were big, but there was denial going on. Right? This was not something you were ready to admit to yourself, and certainly not something you were ready to admit to other folks. Is that paraphrasing what you were saying? Okay, so you did use the term healthy obesity. I mean, you were saying that you were healthy. Now, I have the question for the panelists, in fact, all of the panelists. I mean, is it even possible to be the size, we saw in the picture, and that was pretty big. I mean, can you tell us how big you were at your biggest, or on that picture? 275 pounds. So is it even possible to be healthy when you're 275 pounds? And I just want to start over here and just get a quick answer.
Yes.
It is possible.
It's possible.
It's possible. I'm sensing a but here.
Yeah, it's I'm ambivalent about that, but I think that
yeah, it's definitely possible to be healthy, but I think that it would be rare for an individual of that weight to not experience consequences of their weight. Even if health was totally 100% metabolically, every blood test, everything normal, society and just the world in general has made it that weight will have an impact. And then, of course, there's the physical impact as well. And I think one of the things that's lost a lot in discussions is the impact of weight just on quality of life as a whole. And I think that can't be forgotten in the context of a discussion, even around the fact that there is such a thing as people who are perfectly, entirely, wholly healthy, but might still have consequences of their weight.
So let's go. Let's spend more time on this. Leora, you work in the eating disorder field, where of course a lot of the people that you see are the other spectrum. Their problem is not that they're too heavy. Their problem is that they're too thin. Is weight even a measure of health? Or would it be, or would it not be, or would you put brackets around it? How would you explain this to people who are asking, can I step on the scale and decide if I'm healthy or not?
Okay, so I don't think that so I mean the fast answer is no. I don't think that generally when you're in medicine that you rely on one number to determine anything. And so the fast answer is no, but I also don't think, so the idea that you can be fat and healthy, physically, if you do all the examinations and the blood tests, that there's still a burden because of what society's decided about fat, to me doesn't sit well, because we don't say that about other forms of stigma, right? We don't say, well, the way to solve how people feel about, I'll use something that is personal to me, about being Jewish is let's get everyone to convert. We don't say that. So that if there's a problem with how society views people and how they judge them, our job is to change that in society the way we do with stigma around sexuality, around sexual orientation, around race or religion. That part to me, I think, is we have to be careful not to ask the victim to solve the problem. It's like telling the kid who was bullied that they need to go along with what the bully says, and it's their fault if they're getting beaten up.
So I get that part. I mean, I get the part that as a society, and we are going to be talking about fat phobia, we live in a society where it's not cool to be fat. Although, interestingly, that's where, a big part of the population is actually heading. And that makes it difficult. So the question I think that we need to tease apart here is, when does it just become uncomfortable to be a large person living in a society that does not affect large people and makes life for large people difficult, and so you're not happy, and that affects your quality of life, and so now you're trying to lose weight, and then you might get unhealthy because the practices that you employ trying to lose the weight may not be the healthiest. But the only reason you're doing that is because you don't feel accepted by society. And we probably need to differentiate that from the actual health problems that you might get because you're big, which is, your increase in blood pressure, your risk for diabetes, et cetera, et cetera. So now I want to ask Tavis, because you were kind of reluctant when I asked the question, is it even possible to be fat and healthy? And you were kind of sort of reluctant. So what's your take on this?
Thanks. Well, my take is similar to Yanni's, which is that, of course, there are all kinds of realities that come with being a larger person, and I think Corinne did a really good job, running through some of those difficulties. The other reality is that there is a lot of kind of conflicting research and misunderstanding around the implications of being overweight or obese. And so, there are proponents of fitness as the major determinant of health risk, more important than overweight and obesity, for example. At the same time, so for example, if we look at the Nurses' Health Study, many of you are probably familiar with this, 238,000 women studied prospectively since 1976. That study demonstrated that being a little overweight and a little active was probably not a bad thing. At the same time, across all activity levels, the heavier nurses were at greater risk of mortality overall. So it's a complicated question, and I think to narrow it down to just using weight, I'm probably preaching to the converted for most of you in this room, is unhelpful. And so we need to know about what is the cholesterol level, what is the waist circumference, where is the fat, how's the fat distributed, and so on. Using a number like body mass index, which was developed in the 19th century before calculators or computers, seems a bit silly to make decisions about individuals. Maybe in terms of population health risks and so on, it's helpful. But I think that to get a more complete health picture, you need to kind of I think it highlights an urgent need for realistic, accessible measures, like comprehensive measures.
Okay, so let me take you on the BMI. So it sounds like BMI is not your favorite measure indicator. So now we have Yoni, who's Bariatric Medical Institute, right? That's BMI. All right. So what's your take on BMI?
So it was an unfortunate choice. When we started practice, it was back in 2002. We thought we were very clever. And truly, my practice at the time was very traditional. I went to medical school, and then we learned nothing about obesity, which is typical for medical school. And I sought training outside of medical school, and I was taught to do all the stuff that perhaps some people in this room have done themselves, which is balanced deficit diets, aiming for a 10% weight loss, weighing regularly, meal replacements. I realized very quickly that that was not the way to deal with actual individuals. That was the way to deal with numbers. And we stopped that practice quite a long time ago, but it's difficult to rebrand. So BMI is not, BMI is a measure of bigness. It is a measure of bigness. BMI doesn't measure health. It doesn't measure happiness. It doesn't measure success. It doesn't measure self-worth. It doesn't measure self-esteem, and neither do scales. And yet, the world has been taught that scales measure all of those things, in part from programs like The Biggest Loser, which is shown to over 10 million North Americans on a weekly basis for a good part of the year, and we are having this message drilled into us on a regular basis. So, BMI is a number. I'm not sure that it affects treatment. And I think in medicine, we need to order tests when we have a response specific to that number, and BMI is insufficiently powerful to do that with. And certainly at the extremes of BMI, there's real risk, at both extremes actually. And when we were talking about Corinne before in terms of her weight and her risk, it likely was realized was the impact on quality of life. But I think we need to have a more robust system to determine whether or not someone's healthy, and certainly as a physician, the individual in front of you is a person with a whole long story to explore, rather than just the number that shows up on a scale.
Okay, so it's not about numbers. It's about language. It's about the construct. And we did have, in the meeting that we had all day today talking about weight bias and discrimination, this issue about language did come up. And so I have a question for Corinne here. She referred to herself as being morbidly obese. I think you used the word fat. I've used the word fat. Let's talk about language for a second. What's the language that you're comfortable with, not comfortable with? Do you think that is a big issue, that we need to be thinking around how we talk about this topic at all?
Well, as an obese person, I actually would never use the word obese. I thought it was a horrible word. It was a terrible identifier of who I was. I thought I never used it. I use it more now as I talk about it. Back then, I would often refer to myself as fat, and I would often make the joke that I was PHAT fat and not FAT fat. And again, right, hiding behind that wall that I put up. So, it's I don't know, it's talking about and asking permission, I think, is the biggest part when we talk about obesity and fatness and unhealthiness. And why can't we just ask our patients those questions? Are you willing to talk about these things? And how would you like to talk about these things? Because it's going to be different for everybody, I think.
All right, so in this question, there's of course this implication that if health is something that you could measure by standing on the weight, then there should be something that's a healthy weight. And how many people heard the term healthy weight? Give me a hum. Okay, how many of you know what that actually means, or is there anybody in the audience who can explain to me exactly what you mean by a healthy weight? Does anybody want to volunteer an answer? Anybody? And I'll come to you with the microphones.
I think a healthy weight is whatever your body sets itself at, and what you naturally become when you're eating in a healthier lifestyle and feeling happy about what you're doing and feeling balanced. I think it's intrinsic.
My name's Margie Leach. It's so difficult to define what healthy is anyway, because it's really opaque, and also the explosion of the rate and incidence of obesity tells us that something's going on besides just our bodies being able to regulate what's going on. So there's so many endocrine and psychological and metabolic factors that have to be taken into account, and when you see a very, very large subsection of the population having food-related issues, you have to start to look at what is actually going on and why pleasure systems are being tripped as well in terms of eating behavior. So for our body to just decide, it's very difficult to suggest that just your hypothalamus or the body itself has sort of a temperature regulating it, and that's why obesity is such a complex issue, because so many people don't know. I mean, we don't know how fat communicates with the brain. We don't know the way that neural circuitry is involved with guiding eating behavior, and I think that that's one thing that isn't communicated sometimes with public health and makes all of this very, very confusing.
All right, so to play devil's advocate here, I mean, we have all of this concern about obesity, and we have this fear that some of the population is getting unhealthier, when in reality, actually, there have never been that many healthy people around as a population ever in any time of human history. The world population, at least in most countries, has actually never been healthier, despite obesity increasing rates. I was just reading this article about that there have never been as many healthy 80-year-olds around ever in the entire history of mankind. So on one side, we've got this so-called epidemic where these numbers are going up. We know that obesity is a risk factor for a whole bunch of medical problems. On the other hand, people are living longer and longer and longer, and they're not living longer just sicker, but they're actually pretty healthy. There are a lot of people who reach the age of 60 who are not on any medications, who have no problems, and who may not have the ideal weight or the weight they want to have. So the discussion we're having about what is healthy and what is healthy weight, and do we actually have a health crisis because of this obesity epidemic? Is the obesity epidemic actually making us sicker? So I just want to, I want to throw that out there and get a couple of responses here, and then I'll go back to the panel.
My name is James Fell. I think it's a bullshit term, and I don't use it.
Which one?
Healthy weight.
Oh, you don't use healthy weight. Okay. Anybody else?
I'm a public health professional, and we promote healthy weight below BMI 25.
Okay, where did that number come from?
We just made it up.
All right, let's go back to the panel here.
I think healthy weight is like this magical concept. I don't think we actually have a way of deciding what every individual's healthy weight is. So I can't tell anyone, based on what we know in science or measurement, what their healthy weight range is. And that's the tricky part. We talk about this theoretical construct. We can talk about it at a population level, but everything falls on a bell curve, right? Including weight. And we act as if weight is the single biological measure that doesn't fall on a bell curve in terms of what naturally presents.
David?
I have to jump on the bandwagon here. I can't resist. Tell you why I hate that question. I think actually that question and some of the comments this is one of the reasons for the impediments for a successful health policies around weight. You've got this idea that somehow this implies that people who are of a healthy weight, who have a normal BMI, don't have to exercise, they don't have to worry about what they eat because it doesn't have any sort of implications. You've got overweight people who need to do these things, and then healthy weight people don't have to. And we know that's simply just not the case. And certainly I think from a public health standpoint, the emphasis needs to be on not stigmatizing individuals, but upon promoting a healthy lifestyle, a series of health behaviors, including reasonable portion size and so on for everyone. Yeah.
Hold on, I'm jumping in.
My speaker prog, I've got the mic. You're gonna have to pull it away from me. So
I'm just gonna. He'll get back his mic. Don't worry. So yeah, before you fight it, so I'm just going to add a nuance because you came up with the term not healthy weight. Okay, well, so it's the same question, but let me ask the question. So Yoni came up with this term, called best weight, which is different from healthy weight, and so I was actually going to ask. So I was going to ask you to explain that for us.
that's what I was going to talk about, actually. So when I started practice and I was doing all the stuff I was supposed to do, I was talking about BMI and I was talking about healthy weight. And when I realized how stupid that was and how pointless it was, I came up with a different terminology, which was best weight. And a person's best weight, simply put, is whatever weight they reach when they're living the healthiest life that they honestly enjoy. And that varies for every individual for all sorts of different reasons, some health-related reasons, some quality of life-related reasons. Who am I to judge someone on the reasons they have for wanting to or not wanting to make changes? I can't make those decisions. What I can do is encourage people to explore what their bests are, to explain that their bests actually are quite dynamic. Your best on one day is going to be different than your next day, and that life will affect your best. But I think that, although not useful in research, is a very useful way to think about what is healthy weight. Well, it's different for everybody. It's their best weight.
Okay. All right, so my question to Corinne, are you at your best weight?
Well, that's a loaded question right there. I would say that, growing up morbidly obese, and being stuck on the numbers, right? It becomes a numbers game. You step on the scale and you're not happy with what you're seeing, but yet you are happy. I mean, look at, you've lost 12 dress sizes, you're active, you're eating well. So, it's probably taken me a long time to get there, but I would say yes, I'm at my best weight, despite what the charts say, despite what the physicians say, that even though I'm at the end of, just hitting that obese on the BMI, I think I'm at my best weight because I exercise 6 days a week, I eat nothing but healthy food, and I promote wellness to the best that I can, and it doesn't get any better than that.
Okay, so well, you've hit a nerve. Okay, so what would you say to the health professional or the doctor or the nurse or whoever who said, he said, Corinne, to be honest, I mean, if you really wanted to be healthy, you would have to lose another probably 20, 30, 40 pounds. What would you say to someone like that who said that?
Oh, God. All right, well, first I want to punch him in the throat. I think I've mentioned that before, but certainly that's happened to me recently at my last doctor's appointment. The doctor had commented that I was up a few pounds from the time I had been there 2 years prior. instead of asking me the questions about what have I been doing, you know, this is a new doctor. That's right. My other doctor retired. So I've got this new guy that needs a little training from me, yes? And we'll get there, hopefully, or I'll get fired as a patient. We're not sure yet. But, you know, he said to me, the scale's up. Like, why have you been gaining weight? And I shut down as a patient. I actually got so mad that I couldn't even formulate any sensible words that I could explain to him what was going on. My first time, when he first said, I looked at him, I said, clearly, you've actually never come and heard me talk. And he looked at me like, no. I said, we'll get into that another day. I said, because I think you need to. And then I went on to telling him what I had been doing. You know, as a 275-pound person that's like 5'1" and a little bit, my diet was poor, my health was poor, and I wasn't a healthy person. Now I've started dieting, losing weight, but I took it a little too far. So what had happened is I was actually consuming 900 calories a day. That's not very much. I was below what the experts say you should be eating, and that's what ended up happening. I was so afraid of the number on the scale is that I wasn't eating the amount I should have been eating. So had he asked me the right questions that day, he would have realized that I'm at 1,500 calories a day. I put on 6 pounds of lean muscle mass in the last year, and I'm feeling pretty damn good. But he didn't take the time to ask me the appropriate questions. So therefore, he had a patient that shut down, stopped talking, and now, you know, by my next year's appointment, maybe I'll be able to tell him what he did wrong.
Okay. All right. So what I've heard so far is that there's not a number on the scale that is, you know, that decides whether you're healthy or not. That apparently there's a whole range, and that it depends on all kinds of things, and it's kind of a personal thing. We've heard the concept of best weight. Let's move on to the next question here, because I think there's going to be, so, yeah. What? We've done questions from the audience for now. Let's move on to the next one. So, because we are going to get questions for this one. So if you cannot measure health by stepping on the weight, you know, why do we talk so much about healthy weight? And the big question here, of course, is why do we obsess about our weight? And is there a way that we can talk about health in the context of the obesity epidemic, which undoubtedly we have, in the sense that there are more people now who have, you know, larger clothing sizes. We don't want to use BMI than ever before. Nobody's arguing with that, but is there a way that we can actually talk about this problem without at the same time implying that, you know, that fat people are bad and need to change their evil ways? This is a real dilemma for the population. So let's hear from the panel first, you know, what the spontaneous response to this. Are we doing more harm by talking about this, or is there a way that this can be done?
I tend to work with children and adolescents, so I do also work with adults, and I would say we need to talk less. That all this talking, particularly developmentally inappropriately in schools about numbers and weights, particularly at stages when kids don't even understand conservation of math and can't make any sense of it, and without knowing lots about our kids, we should absolutely teach them math instead. Real math, real English, real geography, none of this healthy eating stuff.
You're not talking energy and energy out.
No, I'm talking, you know,
Calculus.
yes.
All right, David.
Yeah, so I think like traditionally the efforts aimed around encouraging people to lose weight have been fear-based. You know, terrible things are going to happen to you unless you drop a certain number of pounds and so on. And you know, interestingly, like we know from 40 or 50 years of social psychological research that these types of tactics are just simply not helpful for the long term. I mean, at best, you're going to maybe provoke short-term behavior change. You know, give someone a kick in the pants, and maybe they'll be able to succeed. You know, for a short period of time. Of course, like when people do start to move and eat less, engage in all these healthy behaviors and so on, and they drop a few pounds, they no longer feel the guilt and shame that's been induced by their physician visit.
So hang on. So now I'm shocked. You mean the Biggest Loser is wrong?
Well, you know, what's interesting about The Biggest Loser is, of course, it really fits with this notion that you got to go big or you got to go home. And it's got to be fast, and you got to do it the quickest is the winner. And of course, like I'd love to see a show that was about who can keep weight off the longest. That would not be exciting television. I know I'd be like the lone like a supporter of a show like that. And I mean, you know, really you know, a more helpful approach maybe when talking about these sticky, tricky kind of behavioral issues would be to work towards tying the behavior to things that matter to the person. So, like, you know, it's so. I'm listening to Corinne with a sense of dismay when she talks about these interactions with her healthcare providers, where they kind of like assume that her primary motivation is exactly what they're going to tell her it is. And it doesn't take into account what matters for her. Because maybe what matters for you is, you know, being able to go hiking comfortably in the mountains, or, you know, whatever it is. We know that, like, if you tie people's behavior to things that matter most to them, to their values, that's a more kind of effective strategy. And certainly, like, if you indulge me for a second, you know, it's important to point out that, you know, being overweight and obese, that's a normal kind of behavioral choice in an obesogenic society. When you drive down McLeod Trail, there's a corner where there's a Tim Hortons on the right-hand side and the left-hand side. You don't have to turn across traffic. You can pull in. You don't have to get out of your car to get your sugar. You fix. So this is everybody's problem. And, you know, interestingly, like, if I can just sort of take a moment of your time and say, who in the audience considers them, you know, maybe by a show of hands this time, I do want to call people out, to be honest, people, generally speaking, just by a show of hands, who considers themselves to be honest. I really only want to talk to the honest people here. Okay, so most people in this room do consider themselves to be honest. So I'm sort of like the classic absent-minded professor. I've always got stuff trailing. If I were to leave the room and drop my wallet, a big wad of cash sort of falls out, how many of you would, just by a show of hands, come chasing after me to give it to me, if you noticed?
How much is in the wallet?
Let's say $300, you know? So almost everyone puts it in their head, and I would argue with you, that is not the obvious behavioral choice. You should take that money and go and enjoy it. Go to the casino or have a nice night out. But you do it because that matters to you. It's really important to you, that value, despite the fact that it's not the obvious behavioral choice. When we talk about trying to motivate health behavior change, it's important to kind of keep these basic principles of behavior change in mind, I think. And these are not new ideas. These aren't my ideas. These are well-established ideas from 30, 40 years ago.
Okay, all right. So let's stick with the non-stigmatizing way, and I'm sure that Yoni has some very clever ideas on how we can help the sort of the public health folks out of this dilemma. How do we talk about the obesity epidemic in non-stigmatizing ways? How do you even do that?
I think from an adult perspective, it's without numbers, you know, so it is focusing people on the fact that the nonsense from television shows that suggest that there are right places to be and that scales do things other than measure gravitational pull of the earth, those are the sorts of messages we need to fight. I think explaining that there are best efforts that we accept in every other area of our lives, and we're very comfortable with that. I mean, we all fail to some degree at everything, and we succeed to some degree at everything, but if we are doing our best, we're comfortable with that, but not with weight management. And I think that talking about that and also de-emphasizing the numbers, it's not about the numbers on the scale. The goal is the road, not the destination, and we have this culture that is stuck on the destination. And so from an adult perspective, I'm not saying it's easy. In fact, it's extremely challenging because the world is constantly talking about the destination. And even if you provide wonderful messages and ideas in an office setting, you know that, you know, the newspaper, the glossies, the TV shows, they are constantly fighting that message. And with the kids, so I don't work with kids directly. I work with their parents. And with the kids, I think it's really important for the parents to appreciate that the kids are passengers in the cars. They're not drivers. And I really don't think that the discussion of weight management should occur with young children directly. I struggle with that. And studies on programs that don't involve the kids directly show that outcomes are comparable to the programs that do involve the kids. And I guess all I'm getting at is for the parents, what we're trying to work with them on is living the lives they want their kids to live, not talking about weight, making home a safe place, because the world isn't, and homes can be.
Okay. Well, Fiona.
So I would say the public health approach in education is the exact opposite of that, because the message is we've given up on the parents. They don't come to meetings. They don't do anything. So we're going to teach the kids about healthy eating, and then we're going to hope they're going to take it home and teach their parents, which does make the kids the driver, actually, and which I just think undermines parental authority and doesn't work anyways. But that is what people say. So I'm not supporting that position, but I think at this point we're in a culture where weight is so stigmatized that anything sounds like a good idea. We'll make it mandatory. We'll make a legislation about it. We're all in a rush to solve this as a culture, and that we don't stop to think about what the consequences are, and what the consequences are in healthcare. I mean, we talk about physicians saying really horrible things, but we don't talk about how physicians treat people differently based on their weight in ways that produce negative outcomes, in ways where people of certain weights don't get the same treatment that someone of a different weight is, and that's true at both extremes, by the way, and that plays a role, right, in what goes on here too. So I think it's a big issue, and the more we focus on it, particularly because it's a cultural issue, and it's something we wear on our bodies so you can see it, and doctors and teachers are products of the society. The more we focus on weight, numbers or not, the worse this is getting, I think.
All right, so Corinne, let me ask you, at the time when you were still living with obesity, you were still living as a fat person, can you imagine that there could have been any kind of public health message that could have reached you, whether this is through television or a phone call from, your local health minister, or, a billboard sign or a thing that you see on television or a panel like this, that would have, in some form or fashion, made you see the light and decide to become a thin person?
No, I don't think there was. I don't think that would have worked. I don't think I was ready to hear any messaging. I don't think I was ready to hear what needed to be done. I wasn't in that frame of mind. I think I needed to decide for myself what I needed to do for me. And I think listening to all the experts and seeing and being told and having it shoved down your throat isn't going to work. I think you need to be able to plant seeds with patients and people and let them make the decisions and let that tree grow naturally, because often people would say, well, what kept you motivated? Well, it was how I felt. It wasn't necessarily always what the scale said, because let's face it lets you down. It's not your friend. So it's how you feel and how you just become so much more alive, and you can climb those stairs without losing your breath. So I think those were the important things to focus on, and not.
Okay, but I want to get very specific here. So if your local public health nurse, is there anything that she could have possibly done with you in your community, with the people that you hang around with, that would have prompted you to make that move? Is there anything that you're looking at? Had somebody told me A, B, C, D, E, F, G at the time when I was, before I was 40, that would have actually made it different. That would have perhaps stopped me from putting on the weight in the first place. That would have been even better, or gotten me to not wait till 40 to make the change. Is there anything that you could possibly imagine that could have done that?
No, I don't. I don't think there's anything that could have done that.
So you have absolutely no advice for public health people?
I think talking to your patients and just starting to plant those seeds, right? I think it still has to come from the individual. I don't think as healthcare workers you can make people lose weight, right? Then you're starting to play the numbers game, and you don't want to do that. You don't want to start creating other things for people to get obsessed with. You want to be able to have them think and do it on their own and naturally, and not all these fad things. And so I think education to your patient, and let them make the decision of when to.
But doesn't it help to have someone who can show you the light?
Depends on, I still think the patient has to be ready. They have to be ready to hear it. I think if you show them the light all you want, if your message isn't what they want to hear or what they need to hear at that time, you're not going to get through to them. So it's little bits of information and talking to them and not at them that's going to make the day.
I think there are real things that public health can do that might make a difference. Part of me would wish that we focused on other things that we can actually, or maybe looking at what we can do around sexual assault or all kinds of other things, poverty, the effect of poverty, those kind of things, the effect of abuse, all of those antecedents. I sometimes say if we really cared about childhood obesity, we do something about childhood poverty. Because I think sometimes when we situate things in the individual all the time, it just distracts from things we should be thinking about. But an example would be how schools are, right? So in Ontario, there are schools that don't have a lunch hour in the middle of the day anymore. They're too busy trying to get so many activities in, and you can have your lunch at any time of day, including first thing in the morning, and then you have no other break in your day. Workers have lunch breaks enshrined in law, but students don't. And what are we teaching kids about how life should go, the pace of life, and that, aren't we entitled to have a pause in the middle of the day that's social, that we pause to eat, and then the kids, I remember we used to go eat for a bit and then go out and play for an hour before the afternoon started. There was something about that that's gone by the wayside. And in the elementary schools now, they have, some of the schools have 2 slightly longer breaks in the morning and in the afternoon, but no lunch break. And moms have to pack half lunches. What is it that we're doing about, if we want our kids to eat well, why don't we have a national school lunch plan where schools actually provide warm lunches that expose kids to a variety of foods, and instead of telling kids what to do, why don't we just model it? If we want kids to be physically active, let's bring play back. Let's make it fun. There's a lot of problems with this mandatory exercise thing that they do. In some places, the teachers make their kids do jumping jacks for 15 minutes. That's not a way. Yes. For some of us who are not so coordinated, yes. There are lots of things we could be doing. If we want people to not use their cars more, we need to build environments that do that. I come from Toronto, and we're dying for bike lanes, and we had a mayor who made the argument that bikes cause more air pollution than cars do. I'm not joking, because they slow down the cars, who then are idling more and creating more pollution. Really, those are the kinds of things we need to be looking at.
Okay, I get that. So they shouldn't just, actually I would argue they shouldn't just bring back the lunches, they should bring back the after lunch nap. Because I actually went to school where you had to take this nap. I remember as a little kid you had to lie down in school after lunch and sleep. Yoni.
So I agree with Leora. I think that in a sense what we've been talking about, public health can't focus on individuals. I mean, the analogy that I stole from David Katz that I use all the time is flooding, and that, here we've got, if we want to talk about whether it's diet or weight related consequences of our societal changes, it's a flood. And so dealing with floods with public health messages about the importance of swimming lessons and how can you get your kids swimming better, that's not the way to deal with the issue. So if you... Yeah, so sorry about that. But, we need to build levees, and those are changes that affect the entire society and to improve things. And, things like a national school food program we absolutely should have, and we should be bringing back recess, and we should be playing more. There's a ton of stuff that we can do, but at the same time, what I would not want to do is to suggest that we discount the individuals who themselves express interest in making changes. And that was Corrine, right? So, you were the impetus for your change, and you had some help from your doctor, but ultimately, I think that it's a doctor's job to discuss and provide advice about treatment options. And it's a doctor's job to listen to and respect their patients, regardless of their decisions. We inform patients, but we're at least not supposed to judge them on what those decisions are. And I think that's somewhere where we could do a lot better as a profession.
All right. I gotta go.
Just like to pick up quickly on a couple of points, very quickly. I think it was Mark Twain who said, when the only tool you have is a hammer, everything looks like nails. And, this emphasis on educating Canadians about the dangers of overweight and obesity is silly. Canadians already know that it's bad for them. They already know the risk factors. This is not kind of a helpful strategy. Perhaps the best public health efforts might be those that are kind of quiet and happen in the background, like obviously providing children with nutritious food, stop marketing junk food that has no nutritious value whatsoever at kids. Those sorts of efforts seem reasonable, I think, to the group. Yeah.
Any comments on this? No? Okay, all right, let's go. All right, let's go to the next slide here. Okay, questions from the audience. And we had a few arms, hands. Here we go. And just introduce yourself, sir.
Hi, my name is Atul.
Just stand up so people at the back can see.
Hi, my name is Atul. I organize a local vegetarian group. What we can do is we can demand that the government stop subsidizing all the bad choices, because you'll find that the processed foods, the junk foods, the meat and dairy are very heavily subsidized, right? And that's why people are eating it. Also, the oil industry is heavily subsidized, and that's why people are driving more, right? It's just, and we can root out all the corruption within government, right? Within Agriculture Canada and Health Canada, we can demand more accountability from our governments.
Okay. All right. Thank you for that view. Let's go. Let's dive straight in here. Okay. I don't know how far I can go with this, but.
Hi, my name is Sivana. Corinne, this is really more for you. Two things that resonate with me as you were speaking were the permission to talk about being overweight and also asking the right questions. So just looking at those two things, if I am a physician and you are my patient, if I ask you, Corinne, do you want to talk about your weight today? And you say no, is that, obviously I would respect that, but is that more important than asking you, Corinne, how are you feeling? Are you having a hard time walking upstairs? Is it something that I can help you with? Like, I guess I'm going back to you as a healthcare professional. What is really the key of getting the conversation and not be kind of what we talked about, stigmatized, and not talking about weight and not talking about, the things that we tend to focus on versus what you're looking for?
So how do you start that conversation?
Well, I think the second question that you asked, how am I doing? How are you feeling about things? Is there something that you need to talk about? I think those are the building blocks that a physician needs to start with, because they're going to learn a lot about that patient and how that patient's feeling in the direction that that patient wants to go. And I think if we don't ask enough questions, we're not going to find out the answers, and we're going to just be telling and talking to them and talking at them. And if they're not ready for that, they're not going to hear anything. They're going to get frustrated. They're going to feel devalued, and they're not going to come back to their physician. They will avoid going to the doctor regardless how sick that they are feeling, because they don't want that to happen again. That's what I think.
Okay, I saw a couple of more hands up here. Yeah.
Yeah, sure. So my name is Alina. I'm one of the medical residents here at University of Calgary. I have a question for a psychiatrist. I just recently finished med school, and during my psychiatry rotation, I thought it was really interesting because one of the attendings, spoke about obesity as the opposite of the spectrum of eating disorders. So I just wanted to know what your take is on that, and do you think that it warrants sort of a more psychological, psychiatric approach?
Okay. So is obesity an eating disorder, or the other extreme of an eating disorder?
Yeah, so eating disorders are not dependent on weight. That's important. Like, an eating disorder is a psychiatric illness, and it meets the same criteria as other psychiatric illnesses. There are disturbances in cognition and behavior and emotional regulation, and there are, and I'm going to use the word fat because I think that word should just be reclaimed. If we say thin or tall or short, we can say fat. There are fat people with eating disorders, there are average weight people with eating disorders, and there are underweight people with eating disorders. So that weight does not tell you anything about how severely compromised someone is in relation to their eating disorder, or even how close to death they are. It's not a great measure of anything, and often actually in eating disorders we get so caught up in the weight that we neglect the underlying actual psychiatric illness. Not all fat people have a psychiatric problem, and not all fat people need to see a psychiatrist. Saying that, there is a cost in our society for being fat. The I think the stigma and the exclusion and the cruelty can be relentless in a way that can be quite debilitating. And they can choose to seek out assistance the same way someone who's been abused might, for in another way or for other reasons might. But there are lots of happy, well-adjusted fat people out there going about their business, and the best that we could do for them is to leave them alone.
So on this one, I have a question for you, Laura, but also for you, Tavis, because you're the behavioral expert. So what do you do with people who develop, whether it's an eating disorder or activity disorder, because they're trying to get healthy, which is one of the common arguments you hear. So, I've given up all these foods and now I have this very strange eating pattern and behavior, which is really, really weird, but the actual motivation is I'm doing this because I want to get healthy. How do you even deal with that? And because you see more and more of that.
The problem is, just saw someone like that yesterday, thanks to the healthy living intervention. She was so good at following everything they said. And I'm going to quote her. I have permission to quote her. I can remember the day they taught me how to count calories, and I can remember the day they taught me all trans fats are bad. No one ever told me that there might be trans fats in small amounts naturally occurring in things, and that it's a range. They told me all trans fats are bad, so I stopped eating anything with trans fats. They told me sugar was bad. I stopped eating everything with sugar. I think that the issue is that you deal with what you have in front of you. The obvious that these behaviors can continue in spite of the obvious consequences, like you're in hospital attached to a cardiac monitor, and the patient will know that. They still can't stop it. And that's the part you deal with. It's the part where the behavior, to have a psychiatric disorder, the behavior has to cause dysfunction. And that's where you go, is with the dysfunction. And it's about moderation, right? Our grandmothers knew something, everything in moderation.
So if worrying about trying to be as healthy as possible becomes an obsession and actually starts becoming the only thing that you worry about, and actually becomes a problem, how do you approach that from a behavioral perspective? Because I'm trying to be healthy, that's all I'm doing. So I'm giving up all these foods and I'm measuring everything I eat, and I've got my fitness pal, and I've got 4 other different types of ways to monitor my physical activity. I'm monitoring my sleep, I'm monitoring my breathing. I've got this little implant in my tooth that monitors my chewing. All of this is Bluetooth. When does this behavior become pathological, and how do you then address it?
Yeah, well, of course, that's $1 million question, right? It's a very difficult one to answer. And I think it's interesting because you would say, for example, everything in moderation is all right, and I'm not sure about that, because when I think about foods that are consistently linked with disease, that have no nutritious value whatsoever, like trans fats or sugar, I'm not sure that, I think it's time for us to get it going. And while I'm at it, maybe I also like to disagree with Yanni. We're agreeing far too much, so let's get things going. I would almost disagree with Yanni to say, it sounds to me like you're almost giving up when you say to someone, well, here's the information that I'm providing you. If you decide you don't want to change, that's fine. I think as a physician, it's really important to, I'm exaggerating here and misquoting you, but it's really important to kind of, to move people, towards change. Maybe that's the goal of the consultation, not the actual, behavior change itself.
So my only comment is that people are entitled to free will, and adults are capable of making decisions. Everything on moderation. There's a lot of data that says we should not drink any alcohol either, right? And never mind that, it's good for our heart crap, because that's only true for men who are over 40 years old, who are white, from European descent, and what was the other thing, and have had previous cardiac effects. But when you look at the real effect of alcohol, it's not very healthy. But most of us might choose to have wine once in a while with dinner, and that's how life works. If we just spent our lives deciding that we would do nothing that would risk our life or our health, we would never leave our house, right? Let's go driving. I like risking events.
Yeah, the biggest risk factor, as we all know, for dying is being born.
So medicine's not about the delivery of blame, shame, or judgment. It's just not. And so my job in an office consultation, I have a unique population in that everybody who comes to see me is interested in coming to see me. So I'm not dealing with people who are just happen to be there. But even with the population that I see, I will see people who I actually don't think need to do anything. And so these are people who don't have any medical problems as a consequence of their weight. In some cases, these are people, this is the most common cause. I'll see people over the age of 65 who are technically overweight, who are concerned simply because of their weight, who medically are stable and fine. And I explain to them, because it's my job to do so, there is no medical need for you to lose the weight. And I give them that information. I also give them the information that if they want to lose, a little bit of weight, there may not be any risk to that. And I'll talk to them about seeing a dietitian and what they might want to do. And then they decide. For the other extreme, I might see a patient who has a great deal of weight that they want themselves to lose, and they may have very real medical reasons to want to lose it. At which point I will talk to them about their options. There's the surgical option with behavioral change, there's pharmacology with behavioral change, and there's just behavioral change. But my job isn't to tell them which of those things to do, it's just to give them the guidance and to offer the support with whichever decision they want, and to help to optimize their health in any way I can. But that's it. And if they decide to do something that is contrary to what I think they should do, I keep my mouth shut. It's not my job. My job is just to make sure that their decision is informed, and so that they know the medical consequences, if I think there are any, of their decision. And if they choose then to not follow through with the thing I think that would be best for them, well, I'm still very supportive of that, because that's my job.
So what's your take on moderation? Do you like the word?
Well, so, I think there's lots of foods that aren't good for us, and I eat lots of them myself, so it's the smallest amount of the stuff that's bad for us that we need to like our lives. And that's true for everybody and every food and everything, and it changes every day. So, moderation, I actually think that the food industry has grabbed that term and that concept and twisted it to that there is no such thing as a bad food. I think there's lots of bad foods, again, but I think that it is normal and appropriate, and it's part of the nature of life for us to enjoy and eat them. I don't think it's a bad thing to recognize that they're not good for us and they're delicious.
So you're making the distinction here between bad food and forbidden food. So there's plenty of bad food, but there's no forbidden food.
Personally, I don't think there should be, and I've gotten in debates about this before. I think some people do believe in forbidding foods, and that abstinence is the only way to deal with the danger foods of that particular individual's life. I think that in a idealized world, perhaps that would be a way to go, but here we're now talking about something, because usually it's the high-calorie, indulgent, yummy stuff that people try to avoid. But that's also the food that is constantly being thrust at us by advertisements, by friends, by family members, by everyone, every single day. Here we have fruit. We did good. We had not so much before, but Angela. But, so I guess all I'm getting at is that in the context of the world that we live in, I think instead of trying to live with abstinence with a product that is constantly there, it's like an alcoholic where every single day, every day, they are bombarded with advertisements to drink, or their friends say, please drink, and then when they say, no, I'm an alcoholic, oh, come on, you can just have one drink. But that is what people will do with food, and I think that instead of focusing on never, we have to try to help people make changes to allow them sometimes.
Okay, all right. So I can hear you don't like food pushers, which all right.
So I'm uncomfortable with the label, the word bad, because there are some, English is a very messy language, and it's a short step from bad food to I'm bad. And North Americans have a really moralistic feel, in particular, around good and bad. If I eat something bad, that makes me bad. And the consequences of that is that while adults, many of us are affected by that, the people who are really affected by that are children. And I have seen children with their very nice kindergarten teacher being well-meaning, doing a whole month of coloring the bad foods black and the good foods in other colors, and kids not even being aware.
Is there an app for that?
I mean, the problem with that is that kids at some point stop eating food that they need just to grow, because they happen to color it bad. And they're not even so sure about the construct even. They just know it's bad, and bad is dangerous, and it's somehow related to fat, and being fat is bad. we don't like fat people, and you see that happening. We have to be careful how we use these words, even if we understand them or we can debate them. But we are a moralistic culture we're very happy to tell people that they're bad.
Okay, so totally agree. The thing about it all is that it's the context and the teaching that we are doing poorly as a society with. I mean, I think that certainly if it's dumbed down to good and bad, that's a really horrible plan, and I don't think that is the way to go. Teaching matters, and that goes for whatever we're talking about. The informing part is crucial to the conversation, but on a population level, I totally agree with what you just said.
Okay, all right, let's go back to the audience. What else we got here? Come to you in a second.
James again. Mostly for Leora, but anybody else can weigh in. In the last 34 years, there's been a rise in obesity. Also a big rise in the number of fad diets. It seems like everybody on their dog's trying to eat like a caveman these days, or quitting sugar or something equally stupid. There's also been a rise in the variety, frequency of eating disorders. Do you think this is correlation, or is there a direct causation happening there?
All right, well, let's just do a yes or no answer on this one.
I'm only cringing because the researcher in me would tell you can never prove causation. You can only disprove it, right? Like, so I use the word think. Thank you. So you know, if I'm going to go, let's say, anecdotal or opinion rather than pure research, of course they're all related. You know, and if you talk, when I talk to patients that I come into contact with, there are lots of reasons why people develop eating disorders. There's lots of exposure to the pressure to diet. There's lots of exposure to real cruelty and real bullying. It really sucks to be fat, quite frankly, and be a kid. And you don't even have to be fat. You just have to see someone else that's fat. I've seen kids develop eating disorders because they were going to make damn sure they never got fat because they saw their friend being bullied. And there's all this pressure around dieting because, you know, parents are parents with good intentions, because they understand that if you're fat, you're not going to have the same breaks as someone who's not fat. You know, doesn't matter how smart you are, you might not go as far, you're not going to make as much money, you won't get the same apartments. Parents put lots of pressures on their kids to conform too, because they want the same success for their kids. It's like it's good intentions gone awry. We make lots of judgments around fat and dieting, and there are studies that do show that kids like teenage girls who diet through adolescence are fatter at the end of adolescence than teenage girls who don't diet, and that's controlling for their original weight. So it's not like, oh, fatter girls are dieting more, and that's what it is. If you take kids if you control for that, the action of this yo-yo dieting at a time when I think your body's in the process of change and settling and kind of deciding on what the path is, which I cannot stop this conversation without talking about Michael Meaney's work, and I really get a kick out of this. Michael Meaney studies rat licking, and he is brilliant, and I love just saying rat licking. So people are like, what? Who studies that? But he does look, rat licking is the rat correlate of maternal care. So he looks at kind of how, he studies rats, and how maternal care affects lifetime behavior as an adult, and it affects weight as well. And there's some very interesting stuff about adversity and risk of adversity and the kind of parenting you receive, and how that is a message to the organism as an infant to what kind of life they can expect, and that then goes on to determine things like body weight. So really, when I said public health should look at things like dealing with the issues related to childhood poverty, to abuse, to neglect, to unsafe living, unclean water, you know, those are actually the things that might make an impact on long-term health, right? The biggest thing public health ever did was get good sanitation going, right?
All right, we had another one here.
Hi, Leora, I like a lot of what you're saying. It's complex for sure. I'll just give you a little bit of background. I have a PhD in nutrition. I've worked for Trim Gym. I've done nutritional consulting for both morbidly obese and, interestingly enough, now I'm going on to the other spectrum and started up a foundation for eating disorders here in Alberta to expand the continuum of care. And yeah, I really don't like the preoccupation with weight or with good and bad food. There's a psychosocial, cultural, that's getting back to that video. It's so much more complex than that, so I'm glad that you're touching upon that. And then so, you know, as health professionals, knowing that I have been counseling both those with eating disorders as well as those overweight, it really is about motivating them, understanding where they're at. There is typically a denial. They're kind of similar that way. And so how do you get them out of that to want treatment? And that is really getting at those deeper underlying things, whether they be anxiety, self-esteem, body image, change in lifestyle, not being able to do, just happiness factors. So that's my little 2 cents worth. So, well, I wanted to just, you know, just the I'd like to talk about more that, the psychosocial, rather than this good food, bad food, weight thing, because I think we need to start addressing those things and how we can make a change.
And from my experience, I can tell you that there's nothing, I mean, eating disorders, obesity, they're not they don't have a monopoly on denial. I mean, you know, I've met people with almost any disease you can possibly think of who are in denial. So I don't think that that's in any form or fashion specific to the topic here.
I agree with you, and my comment also, I think, really something you said earlier, though I'm not going to be able to quote you exactly, but this idea of we should push people to get the most they can, like don't just settle and let them make their own decisions, like should we push more? I want us to also remember that sometimes people are more than just their weight, and sometimes they actually have other issues going on in their life that losing weight might make significantly worse and lead to a terrible outcome. Like sometimes actually it's actually better to be a little fat than to go all gung-ho on a procedure or in a process to lose weight and trigger unresolved trauma and severe PTSD and spend your life all day in a flashback and no longer be able to work or manage your life. Like really there's a balance of what is it that you'd rather live with? Recollections of the horrible childhood abuse controlling your whole life or being heavier? And people should get to decide that. That's all
No, absolutely. I mean, if you're eating behavior, if food is your coping strategy, I just can't take away your food. Right, I mean, that's without giving another coping strategy. We had another question at the back over there.
Hi, my name is Casey, and my question to anyone who wants to answer is, what is your take on the intuitive and mindful eating movement, which is more so kind of away from the numbers and more towards tuning into your inner wisdom, let's call it?
Inner wisdom. Here we go. All right, who wants to take this one? Let's start here. What's your inner wisdom? What does that help you?
Oh, I don't have any inner wisdom. I would say that when I was morbidly obese, my inner wisdom was missing. Often, you know, the dietitian would talk about, you know, satiety and not, you know, stopping when I was full, and I would often thought, I wasn't born with that. How do I get that? So I think it took a long time and a lot of listening to myself before I found that inner wisdom and that mindfulness. So I don't think it just comes naturally. I think you have to work at it and learn to listen to your body, and it might take somebody a really long time to get there and understand what that is that's happening to them.
Okay, Davis, mindfulness.
Well, it's a timely topic. Timely topic for sure. There was just a meta-analysis and systematic review and a company meta-analysis published last month looking at the impact on weight loss, and it was very encouraging. And you know, I think that of course the food industry in particular does a really good job of messing with all kinds of satiety cues, with you know, everything from portion sizes to pictures and so on. And certainly, like I think Corinne's right. Like this is it's a teachable, learnable skill that one can cultivate. The opposite of kind of the mindful eating maybe that I'll do while I get ready to take my daughter to daycare by hanging over the sink and chugging down a box of cereal. But it's well, you know, like my problem is when I try to do that with let's say foods that are not super nutritious, that my entire day ends up filled with me eating moderate amounts of foods that are not great. So I'm not sure what the question was about the mindfulness approach.
How would you prompt somebody to?
Well, you know, like again, it's a skill that requires practice, and so like you know, you can't sort of have a one-shot kind of training session with someone and tell them like this is what you're going to do. Best of luck with it. Requires like you know, best practice would be daily practice for about 8 weeks. It's like learning any new habit, whether it's driving or playing the piano, the basics or whatever. It takes some time, but it's something that everyone can cultivate. Maybe not as well as the Dalai Lama, but perhaps a moderate.
I've been struggling with this a little bit lately because I'm thinking mindfulness and intuitive eating get lumped together. I don't think they're actually the same thing. I think mindfulness is something that you can use as you learn to do intuitive eating, but I'm not sure that when you've established a habit of intuitive eating, you need to overthink it all the time. Like, intuitive eating also shouldn't be something you spend all your time thinking about or focusing on. But I think mindfulness is a useful way of getting to intuitive eating, and I think most of us, I would agree with you on this, most of us have had that kind of beaten out of us by the time we're 5 or 6. So it doesn't even have to be the media and the food industry. I mean, I think anyone, just read Alan Satter, you know, anyone who's read her stuff. Lots of rules we impose on our kids around not letting them listen to their own hunger and satiety cues. Those kind of things already affect us before we even know what's going on. And so I think I think it's the process of relearning it to a large extent. But I also think that the kinds of things we want people to do as individuals, including not chugging down whatever, disregards the really lived reality of many people and how hard it is to get through your day if you're a single mother on a limited income without any supports and children with multiple needs. And sometimes you just have to get through the day without anyone killing another member of your family, and you do whatever you have to do to get by. And I think we need to be respectful of that. We are, you know, healthcare professionals and professors and researchers. We are fairly entitled, and we need to remember that not everyone lives in these conditions.
All right. So before we get into the kumbaya moment on the panel, I am a bit mindful of time. We're approaching 9 o'clock. I mean, I'm sure the topic, I mean, it can keep me here all night because I love talking about this stuff or listening to these experts. Any urgent questions? Okay, we got one last one. This better be urgent, okay? All right, here we go.
So we keep talking about public health responsibility, the responsibility of healthcare professionals. There's a lot of healthcare professionals here. Where's the patient in all of this, and where's the patient's responsibility? So maybe, Corinne, you can answer that because you're both a healthcare professional and you were in a situation where you had to make decisions regarding your patient.
Okay, so where's the patient responsibility in this? Corinne, at what point should you have taken responsibility?
I think I did. I did take responsibility. I think it took a long time for me to understand that I needed to do something and own up to it and stop lying to myself, but I did take responsibility, and I think patients all will take responsibility in their good time, and I don't think we can make them do that. I think it's important to, again, talk with them and find out what's going on, right? Because you can't make them do it. So, you know, patients have a huge responsibility in their own care, but give them the options, give them the plans, give them everything so that they can make a absolute informed decision about which path they want to take and how they want to take it and who they want them help to take that with, right?
That's fine, it's fine, it's perfect. So it's a question that I only ever hear asked about obesity. And I think that really speaks to what we're talking about here today, which is weight bias. So the vast majority of chronic diseases that we have are preventable by means of lifestyle changes and behavioral interventions, yet we only seem comfortable suggesting that patient responsibility matters in obesity. And I don't think it matters in anything in a sense, because our job is not to blame the patient in front of us, but rather to try to understand if they're not doing something that might benefit their health, why, and is there a barrier that can be overcome? And so it's an interesting question because, again, it's only ever posed in forums like this one.
Sure. This is a, I think this panel discussion has led to maybe more questions than answers, but it's a very different issue than other public health successes in the past. I mean, when it comes to smoking, the idea was, stop smoking altogether, it's bad for you. Everyone can agree on that. With eating, of course, it falls along a behavioral continuum, and there are problems at both ends of the continuum. And it makes it like a special problem, but again, one in which it's really important to kind of, I think, point out is being dealt with in a manner very similar to very dissimilar types of public health problems. And we need to move beyond, I think, like creating fear appraisals, from providing people with information about things that they're already well aware of, and work towards like a great deal more sophistication. And this I'd really like. I think that your remarks were excellent in terms of like all of the contextual factors for, when I was living in North Carolina, it was not uncommon to see like, black women over the age of 30 who was morbidly obese. And, when you're a single mom and you're working a couple of jobs and you've got kids to take care of, you're going to eat what's fast, cheap, and available. And that makes a lot of sense. Thank you.
So I do think patients have one responsibility, and not just patients of a certain weight. Every time you are a patient and you are being treated disrespectfully or inappropriately because of your weight, or any time you have a child in school who's being exposed to things that are unrealistic or bullying, or presenting things in a weight-biased way, I think you need to hold us accountable. You need to complain. You need to write letters to our colleges. You need to sue us. You need to make us accountable when we do wrong. What I see particularly in weight-related issues is that people are so feeling guilty and unentitled themselves that they take a lot of crap that no one else takes. So the responsibility I think we all have when we are patients is to demand to be treated with respect and to be entitled to the same treatment that anyone else gets. People with eating disorders often get turned away and don't get examined in emergency departments, and there's lots of evidence for this. Even if they present with typical chest pain, we wouldn't do that to a smoker who showed up with chest pain. We don't say, come back when you stop smoking. We do the EKG. But I have patients, I have seen it with my own eyes, that are told, come back when you start eating. So every time that happens, we should complain.
Okay, so on that profound note, which, by the way, I wholeheartedly agree with. I mean, there is patient responsibility, and part of the responsibility is standing up for yourself and standing up for getting the health care you deserve, and whatever the problem is. I mean, that's what our job is to provide that health care, and you have a right. That's where your tax money goes to demand it. So on that note, I'd like to thank you all for coming out. I'd like to thank the panel for being very collegial and only beating up on each other in moderation. That was good. I'd like to thank all of you for coming out for this. It was, I'm sure we could have, there's lots of questions we could have posed and talked about. This is an important topic. I hope none of you came here looking for the latest fad diet or how do I lose weight. I'm sure very few of you will have lost weight this evening, but don't worry about it, okay? It's not important. See y'all.